Welcome to Quality Matters, where we speak with experts across industries to see how their perspectives can inform our pursuit of high quality education for all students. I'm Shaka, and this is Caitlin, and we're happy to be your guides for this limited series.
Like you, Shaka and I are passionate about all students having access to a great education, and quality is a driving force behind our work. But what does quality really mean? In an era where parents can customize their child's education, this question is more important than ever.
During each session, we'll hear from leaders in education, technology, business, sports, and the arts. We hope to apply their insights to our pursuit of a great education in the K-12 space.
Join us on this journey to secure a great education for all children. This is Quality Matters. Well, welcome to Quality Matters. Today, we're here with Dr. Ken Sands, who is the Chief Epidemiologist at HCA Healthcare and a Colgate graduate as well.
That's right.
And we're so excited. We're excited to learn about not only your experience in healthcare and specifically as it pertains to quality, but we're excited to have a conversation and learn more about you and your work and share a little bit about how it connects to Quality Matters and the education world in which we live. So I think to sort of start us off, you have had lots of experience. I think I saw that it was decades of experience in over 20 different states working in some capacity. And I'm curious, as you look and assess, quality, what typically starts and what informs your opinion of quality and what informs sort of how you assess quality in your work, quality in different systems, quality in the medical field?
Yeah, these are great questions, and it's a pleasure to be here. As you mentioned, I've been in this role for quite some time before going to HCA Healthcare at a teaching hospital in Boston. And so I've been part of evaluating quality in healthcare for a couple of decades. And healthcare is complicated, it's expensive, and it's important. And measuring quality can be difficult. Personally, I've liked the framework that a group called the Institute of Medicine, this is actually now called the National Academy, came up with about 25 years ago now, where they said that the best way to think about quality in healthcare is along the lines of 6 dimensions. That you want care to be safe, that you want it to be, so we don't want to be hurting people while
Sure.
you're providing care. You want it to be effective. We should only be doing things to people that we know actually makes them better.
Mm-hmm.
You want it to be efficient, meaning we don't waste resources while we're doing things to people. We want it to be patient-centered, meaning that we do things in a way that is puts the patient in the middle, that is responsive to their needs. And you want it to be equitable. You want it to be all those things while at the same time being done in a way that's blind to race or creed or background and all those things. So that framework, I think, resonates. And I've found that it is something that you can use when talking at the level of a large system,
Yeah.
such as HCA Healthcare. We are, as you mentioned, we're in 20 states. We have hospitals across the country. And so we can be looking at those 6 dimensions, or you can be looking at the individual level and asking, am I practicing in a way that's safe and effective and
Right.
efficient and patient-centered? So it really captures the fact that healthcare has multiple dimensions, and what is important to the patient may be different than what's important to the system. But that's a nice way to capture it all. And I'm realizing I only mentioned 5 dimensions, but the 6th is timely. That care should be delivered in a way that's timely. There shouldn't be waits and delays
Yeah.
in terms of people getting the care that they need.
Yeah.
So that's a nice framework, and there are ways to measure all of those dimensions in healthcare.
Well, I can't wait to hear how you measure them. I mean, I think that's a very natural next step and the next question, because what you just described, oftentimes you can't measure what you can't name, and you just named something very specific. You named a really concise and clear framework for how you measure the quality that you're looking for. So when it comes to actually assessing that quality and ensuring that you're achieving it,
Mhm.
what does that look like for you guys in your work?
Yeah, there's usually looking within certain episodes of care, you
Mm.
can look for ways to measure quality. So, if the domain is surgery, you can look at safety, such as the avoidance of infections
Mm.
following surgery as a measure. That's something that wouldn't be in the safety domain. In the effectiveness domain, uh, has the person's quality of life improved by virtue of the fact
Hmm.
that they've had the episode of care that they wanted. You can measure things like timeliness, like what were the waits and delays related to receiving care. So there's ways to measure that. Uh, Among the hardest measures to assess is equitability.
Mm.
Uh, it on a macro scale, it's probably one of the most important dimensions. There's lots of evidence that uh, in the U.S., one of the highest predictors of health is still race,
Right.
and so we know it is an issue. When you get down to the hospital level, it can be difficult to measure the degree to which you are providing equitable care or not, just because it's difficult to gather that information.
Mm-hmm.
But most systems are committed to trying to measure equitability along with all those other measures.
Dr. Sands, yeah, these 6 dimensions seem really transferable to the education
Absolutely.
space. I think
Mm-hmm.
we're absolutely going to talk about that during our breakdown. One of the um, one of those areas that you mentioned is whether or not something is patient centric.
Mm-hmm.
And in education, we talk a lot about things being student centric,
Yes.
but that to me um, seems a little bit more amorphous, like student something. Whether or not something is student centric seems a little more amorphous than whether or not something is timely, right?
Mm-hmm.
If something is timely, I know that a clock's going to be involved or
Mm-hmm.
some measure of linear time. What's that look like in the healthcare space, determining whether or not something is patient centric, and is that kind of one of those areas, or maybe you can give us an example. So here would be something that we would decide is more or less patient centric.
Hmm.
Yeah, I would say examples of patient centeredness would be I can see the type of provider that I want.
Oh, yeah.
If I prefer a female provider, that's available to
Mm.
me.
Okay.
If I need to be seen uh, in my home
Hmm.
because I have transportation issues, then that would be more patient centered.
So almost a
Um,
little more of these subjective or sort of uh, some of those unique patient needs that might be different from between patient A and patient B, right? Caitlin and I are going to have some different preferences, for instance.
Right. So, I mean, non-patient centered care it would be, you know, I only see patients from 10 a.m. to 10:30, and
Right.
if you want to see me, that's the only time I
Come
make
in
it.
that time.
You
Yeah.
have to come at that time, and I'm not going to accommodate the fact that you're a school teacher and it's not
Yeah.
possible for you to come between 10 and
Sure.
10:30. So that would be, what it looks like to be non-patient centered. To be patient centered is for the system to be looking for ways to make sure that the system is responding to the needs of the patient. That might involve making sure the person has a translator. It
Hmm.
might involve the fact that if it's important for the person to always be seen in the presence of another family member, that you accommodate for that. So those would be examples of patient centeredness.
That's really helpful. Thank you.
Mhm.
So I'm interested, in this idea of you have 12, or excuse me, hospitals in 20 different
Mhm.
states. You've got decades of experiences. There had to have been some moments where mistakes were made
Mhm.
or challenges were presented, failures were had. And
Mhm.
in the healthcare world, those can be a matter of life or death. In education, we certainly have enormous stakes at hand
Mhm.
when mistakes are made and, a child's education is at play. I'm curious, have you found, or probably the better question is, in what ways do you navigate those mistakes and those challenges and those failures so that the outcome is positive in some situations, or so that you don't repeat them a second time?
Yeah, great questions. So the same entity I mentioned before, the Institute of Medicine, now the National Academy, is similarly put out a report uh, a little bit before the previous one I mentioned, called "To Err Is Human,"
Okay.
and it was about principally about safety in healthcare, and looking specifically at the issue that mistakes are very common in healthcare,
Hmm.
and harm is common. That there's definitely a large safety agenda in terms of preventing error and preventing unintentional harm to patients that are receiving care.
Hmm.
So why does that happen? Well, healthcare is complex. Uh, there's a lot of moving parts,
Hmm.
uh, and it's provided by human beings, and human beings are capable of making mistakes.
Yeah.
So, I mean, it's always been true, but I think what was really surfaced in that 1999 report from the Institute of Medicine was this is a major health issue in the United States, and we all should be really focusing on safety in healthcare. Uh, how do you focus on safety? Well, you can track the occurrence of events, and we track things like infections that
Hmm.
occur in the hospital. We track other uh, kinds of harms that can be common in all hospitals, such as patients having falls, uh, patients having medication errors, and we try and reduce those. And the best strategy for reducing those is creating an environment where healthcare workers feel safe reporting
Mm.
Mm.
on events when they occur, and even more importantly, when events almost occur,
Okay.
the so called near miss event. And the
Yeah.
idea here is whoa, I almost gave this wrong medication because the vial that it's in looks a lot like this other vial.
Yeah.
And I didn't actually do anything wrong. Everybody's fine.
Right.
But even still, I'm going to stop what I'm doing and I'm going to tell my manager about that error so
Sure.
that you can correct the problem,
Right.
correct that look-alike error before another patient is exposed to it.
Yeah.
And so if you can build that culture where people are thinking all the time about the potential for error
Hmm.
and reporting those events, and hospitals that are good at this will actually celebrate those near miss events, and they will have maybe an award each month for who identifies the
Yeah.
the best near miss event, so that you can just sort of highlight and credit people
Yeah.
with the things that they are doing to make the environment more safe.
That's
Hmm.
tremendous.
Hmm.
It makes me think of, we've joked today about this idea of feedback being a gift. But
Hmm.
in the example that you just gave, the hospital is incentivizing people, their practitioners, to give feedback on the systems and to feel comfortable doing so, is what it sounds like. And, feedback as to where they were almost making mistakes, or if something's looking alike, then they're creating opportunity to change that and make it better. And
Right.
they're owning that accountability and their involvement in those processes.
Exactly. And 99.9% of healthcare workers show up every day wanting to make people's lives better
Of
and
course.
and help people. Uh, and when they make an error, they they want to make sure that it doesn't happen again.
Right.
Hmm.
And so creating the environment where people feel safe saying, "Whoa, I did the wrong thing. I'm a human. Anyone else could have done that. Let's correct this."
Right.
Then that's the goal of any program.
Yeah, it's really interesting. It strikes me that that if we saw then a system, and that might be healthcare, but frankly any industry,
Hmm.
and that industry said, "Hey, guess what? We have a 100% all-time accuracy rate." We'd
Hmm.
sort of have to say, "Well, then I think you have a misreporting
Hmm.
rate,
Correct.
right? Because
Yes,
as you mentioned, to err is human. We are fallible, right? And so things are going to happen. But if you've got frankly, if you've got 100% quote 100% accuracy rate, it might mean that you don't have a culture that is accepting and willing to take in that feedback and make the changes.
that's right. And what hospitals that are good at this do is they track how many reports they're getting of no harm events
Hmm.
and how many reports they're getting of harm events. and as your culture improves, that ratio changes, where you
Oh.
start seeing more no harm events and less harm events, and you sort of can't have too many of these. There's just you're always looking for people to be reporting more because there's just always opportunities to make things better.
Well,
So trying to get those numbers up is part of the culture.
Dr. Sands, I wonder if you can think of a time um, when you saw the healthcare, whether it was the healthcare industry or a particular hospital, but probably it happened at a more macro level, um, where there was something that was thought of as a a best practice or a useful practice, and actually over time the industry said, you know what, that's actually not adding a ton of value
Hmm.
to um, the health outcomes that we're pursuing or patient care, et cetera, and we're going to stop doing that. Are there
Mhm.
things that because I've got to imagine as new research comes out, as new things are, innovation, um, we want to incentivize innovation. It's got to mean that we're also shedding some of the things that in the past we thought were valuable and we're no
No
longer
longer.
doing. Yeah.
Yes, there's lots of examples of that, and I can think back to when I was a resident. There was a procedure that was done commonly in the intensive care unit,
Hmm.
which was to use a special type of catheter called a Swan-Ganz catheter, uh, which had a, um, a probe and a measurement on it that allowed you to measure um, the pressures on the pulmonary side of the circulatory circuit, which you can't get from doing the peripheries. And it was thought that if you had that information, you could better manage an ICU patient's physiologic status,
Hmm.
their hemodynamic performance, and it's a dangerous procedure. I mean, it takes time. It's complicated to float that catheter and get it into the right position, and then there's always a risk of infection. But it was the dogma when I was in training was that it was an essential part of managing a complicated intensive care unit patient.
Mm-hmm.
Well, as time passed, they did the literature and showed most patients don't benefit from having that
Mm.
catheter in place, that in the end it wasn't really changing how patients were managed.
Mm-hmm.
And so now it's rare for those patients to get those catheters put in place. There are sometimes still situations where it's appropriate,
Mm-hmm.
but it's much uh, less common. It used to be, okay, patients being admitted, okay, who's going to put in the Swan-Ganz catheter? And now it's much less
Mm-hmm.
of an automatic. So
Mm-hmm.
that's one that popped in my head.
Yeah.
Um, but there are lots of examples of things where uh, there's an impression that it makes a difference, but then as measurement gets more sophisticated, it's harder to show that there's a difference.
Yeah, yeah, that's really interesting. It makes me just real quick, Caitlin, before you jump in, it
Yeah.
makes me think about just how many things in the education space we memorialize
Mm-hmm.
and we put it in policy and we say, okay, here's how it's going to be, and then it's very very rigid,
Mm-hmm.
right? And you look at even the number of school days, right? Most states have a legislative, a sort of statutory minimum number of school days. There's nothing sacrosanct about 180 days in
Yeah,
a
right.
school year, particularly when it's not even in a calendar year,
Mm-hmm.
but um, sometimes we get stuck, I think, because no one questions that conventional wisdom, and we're not thinking in an outcome focused way.
Mm-hmm.
So you were kind of going the same direction that my brain was going. It's sort of this flip side of innovation where you have practices that, no longer are proving to be valuable. What about taking a risk or taking a chance when you do implement new practices and they haven't been done before?
Hmm.
But similarly, when in teaching, the stakes feel super high. You want your students to be able to leave your classroom and know how to read. And there's a certain way that it's typically taught, but there's potential that there's a new way out there to do it differently and to have more success or to, create greater comprehension strategies for your students if you change something. I'm imagining when you guys evaluate what new practices to start um, engaging with or to start implementing in these different hospitals, there's a whole process of evaluating whether taking the risk and trying these new things is going to be helpful, and it's going to produce fruitful outcomes. I guess to sum it up and to sort of rephrase my question in a more succinct way, what does it look like to practice innovation in your world and to implement new innovative strategies when you're managing all of what feels to be on the line?
Yeah, another great question. And there's the mantra of first do no harm. So the
Mm-hmm.
Okay.
first thing you got to be thinking about is are we doing something that might have a downside, and if so, you sort of can't go there.
Sure.
But a lot of what we do in terms of innovation is in the space of process.
Okay.
What can we do to make it faster, easier for clinicians to have the information in front of them that they need to in order to offer better care for patients. So we've done a fair amount of innovation just in terms of creating visual ways to assemble information for clinicians so that they can react better to a lot of information
Mm-hmm.
that's coming at them.
Yeah.
One of the problems in healthcare right now is there's so much information, and if you're a physician managing a patient in the hospital, you've got vital signs, you've got labs, you've got
Yeah.
medicines that the person's on, you've got the past medical history of what they're on there, you've got what the patient's telling you in terms of their symptoms, and trying to uh, balance all that information
Yeah.
and make sure that you're making sound decisions is something that we think that we can innovate and make that a better process. Um, so that would be one example, and that it's typically iterative. And the nice thing about where I work, where we have a large number of hospitals, is uh, we can pilot what we think is a promising innovation in one or two hospitals, and if it's
Yeah.
promising, we can spread it.
Mm-hmm.
So that's the typical way things would happen in our system or in another system. Pilot, make sure it works. It's doing what you think it will do. It is improving care, and then if so, you can decide how you're going to scale it to the next level.
Mm-hmm.
It's just making me think about, healthcare, like education,
Mm-hmm.
is so personal
Mm-hmm.
and it's so individualized. And yet both operate in these enormous systems
Mm-hmm.
and they have to somehow contextualize what it looks like to get very personalized care, like truly personalized care and truly personalized, individualized education, and simultaneously exist in these enormous
And
systems
do it at scale.
and do it at scale
Yep.
and do it in 20 hospitals or do it in 100 hospitals. And I just think that's one parallel between these two industries that's unique, because I don't know another. I can't think of another situation at the moment where it is both. The stakes are high and you're sort of navigating, like the physicians these days, so much information,
Mm-hmm.
and then trying to make decisions that are very personal and very individualized.
Yeah.
Yeah.
One of the things I love, and I'm so glad you came to speak with us at Quality Matters, but it makes me think maybe we need kind of an educational Hippocratic oath, the sort of let's be innovative, but first do no harm. And I hear you talking about that, Dr.
Mm-hmm.
Sands, in your work. So thanks so much for joining us on Quality Matters. We're going to have a really rich conversation
Yeah.
during our breakdown. We really
Yeah.
appreciate it.
Well, great being here. Thanks so much for having me. Enjoyed it.
You bet.
Thank you.
All right, another great conversation in
Yep.
Nashville with Dr. Sands, talking about the healthcare world and relating it to education. Ample opportunities for us to draw connections,
Mhm.
to draw parallels. There were so many things that he was saying that I was thinking nonstop. Schools should be doing this.
Yeah.
Why are schools not doing this? If a school leader was listening to this conversation, they would have something new to take back with them. So I'm curious, as always, what stood out from the conversation to you?
Well, the first thing is that when he was working at a healthcare system in Boston, he was the chief quality officer.
Mm-hmm.
So let's let's just name that, right?
Right.
What if your school district had a chief quality officer and they had to actually say, well, here's what we mean. They would have to articulate what quality outcomes matter. They'd
Mm-hmm.
have to articulate how you're going to pursue those various outcomes, right? So sometimes just putting it out there,
Yeah.
kind of, speaking it into the universe, if you will,
Right.
I think can be really powerful. And so the fact that he was just focused on that, and then I thought he did a really helpful job in naming those 6 different domains of quality. And I guess that's, across the healthcare sector. But the ones I latched onto were, that patient centric,
Mm-hmm.
patient-centered outcomes. And that was really important because I heard him talking a little bit about some of the things that are, a little more subjective, right? It just necessarily, you and I are gonna have different um, preferences and desires when we walk into a primary care physician's office. We're gonna want
Mm-hmm.
different things. We're gonna have
Mm-hmm.
we're certainly bringing different histories with us,
Yep.
and so there's got to be some customization
Yeah.
to the patient.
Yep.
We can't be satisfied. When he was talking about, when I asked him and pressed him a little bit and said, well, what would be the opposite of patient centric? And he said, well, if we said, um, as a physician, the office is only going to be open from 10 to 10:30, and you're a school teacher, so too bad for you.
Mm-hmm.
I know that's something that a lot of teachers listening can
Yeah.
resonates with.
Well, it just makes me think of how many students are told this is the way you have to take, this is the
Can
way you
learn it
have
this
to
way.
show your knowledge.
Yep.
This is the way we're teaching it.
Yep.
If it doesn't work for you, then either you must not have the knowledge or you're not capable
Yep.
of figuring it out. And you're talking about a child who might not have the skill set of being able to teach themselves how to learn.
Right.
And if you're talking about an older student and you're giving those parameters, it's to me seems like a recipe for failure,
Yeah.
and it's on us to figure out how we need to change the way we are delivering instruction, the way we are setting expectations, not to make it, every single student does not need one specific teacher.
Mm-hmm.
That's not that's not at all what I'm saying, but there are ways to create environments where you are allowing students to learn what needs to be taught and to learn what they need to in order to become valuable contributing members to society, and also individualize their experience, whether it's through instruction or through, um, assessments, so that the students and the kids are able to achieve,
Mm-hmm.
what's needed, what's required of them, and doing it in a way that's individualized and personalized, which made me think about, I'm curious what your thoughts are on this idea of schools, like I just mentioned, being personalized, individualized, the
Mm-hmm.
need for both of those. Um, and then also in healthcare, having the care, your medical care, be very personalized and individualized. But then they're operating in these enormous systems with all these different parameters in place. What does that, I mean, do you have thoughts on
Mm-hmm.
how to do that successfully? Or is something coming to mind where you're like, oh, this is exactly how someone else is, doing it maybe in a way that's
Well,
beneficial?
one of the things that strikes me about the healthcare system is that there seem to be some almost self-policing mechanisms that are
Okay,
in place
interesting.
in the healthcare system that are not in place in
That's a great point.
education.
You mean like when he was talking about the self-reporting of near misses?
Correct.
Okay.
Yeah, he's talking about self-reporting of near misses, and that's a great dynamic, and this probably sounds really counterintuitive to a lot of people to go like, "Hey, you're gonna get an attaboy for saying that you almost gave someone the wrong medication."
Yeah,
But really, what it's saying is, I think there's sort of a dose of humility there that says,
100%.
"Listen, I'm fallible, and you don't need to rely on me to be 100% on my A game for you to have good outcomes.
Mm,
I should be able. I don't want this to sound like I'm denigrating anybody, but um, we should want some of those things to be kind of like idiot proof.
yeah, exactly. To account for humanness.
Yeah,
What? The book that he
To
said.
err is human.
Yeah.
Because in some ways, and so here's how I think it relates to education a little bit. We often hear, and you were a teacher, as a school administrator, we often hear that just about the importance of a good teacher.
Mm-hmm.
And I want to say yes, but when we say a good teacher, like um, we don't, we can't expect every teacher to be an actual superhero.
Mm-hmm. For
Like
sure.
we need to if the system is working well, I think it would be working well even when teachers come in and they're not feeling like superheroes. They're
Mm-hmm.
just feeling like, average humans,
Right.
right?
Right.
We should expect that an average human can do this job.
Yeah.
And I think physicians are great and healthcare professionals are great, but they're not actual superheroes. We need them to do the work and to treat people um, towards positive health outcomes, even when they're just average in their field.
Okay, so how do you juxtapose what we're talking about right now,
Yeah.
which I'm totally in agreement with? I think we'd be hard pressed to find someone who's not. And with this idea of not under expecting from our students. Like what we're describing right now
Mm,
is we need to account for humanness.
mhm,
Err to err is human. Okay, well, when we have these students, we're telling them, the sky's the limit. And I'm thinking as I'm talking through this because I don't have a
mhm,
preconceived idea, but what does the balance look like to expect a lot from all of these different
mhm,
people and then to also account for life, humanity,
mhm,
all the other components, and
mhm.
the dimensional
Yeah,
world of
yeah.
living?
Listen, I don't pretend to have like a real tight answer
Yeah.
for that. But one of the things that comes to mind is this idea about like mastery in
Okay.
education, right? And so you're familiar with this concept, but kind of the idea that like a student should move on to new kind of new information, new lessons, new challenges once they've mastered the existing ones, right?
Hmm.
As opposed to what we currently do in most schools is say, well, congratulations, you had a birthday,
Yeah. And
and
therefore,
and
you
therefore
next material.
the new material comes. Like in some ways that's kind of crazy, right? there's
Yeah,
nothing
that's so interesting.
um there's nothing that happened. I don't remember anything happening between my 8th and ninth birthday
Yeah.
that where I woke up at 9 years old as compared to the 8-year-old Shaka and was like,
Now you got it.
now I'm ready for fractions,
Yeah.
right? And so I think about like what does it look like maybe to um if you're paying attention to when an individual child masters something,
Hmm.
then that's a lot more personalized. It would also schools that do this, I think, are also like kind of disaggregating the subjects a little bit.
Okay.
So what I mean there is um you might have been great at math, but struggled at some, English language arts concepts.
Yeah.
Yeah, because these things don't necessarily move in tandem, right?
Hmm.
And
Hmm.
so how are we giving you content maybe that's appropriate for even the subject at the right level? And allowing that kind of flexibility and allowing a school to be nimble like that, I think is
Yeah.
really helpful, benefits kids.
Yeah, I agree. This idea, and I guess it was a little bit spoken about before when you were discussing the personal autonomy, or maybe it's the empowerment, or I'm not sure the right word, but teachers or physicians, there's that level of there's that component
Hmm.
of measuring quality, assessing quality, understanding quality, and then there's the stakeholders, the patients or the students, and it's making me think of the conversation we had with Eric and Ben a while ago, the quality of input
Hmm.
and versus the quality of output. And if you're, you know, um, if you have a high quality of input, you're highly likely to have a high quality of output. In healthcare and in schooling, when you have practitioners and you have systems that are measuring quality, built to sustain the quality, and then each of the participants is focusing on monitoring themselves in the process, you're going to have much higher outcomes and
Hmm.
you're going to have much
Hmm.
higher quality outcomes.
Yeah, yeah.
But what you were saying is that we see a lot of that, and Dr. Sands mentioned that in the conversation in healthcare. And I don't know why we don't see more of that in education, where teachers are self-reporting or even self-identifying areas where that need tweaks
Mm-hmm.
or that need adjustments,
Mm-hmm.
so that the quality of input into this, system of education is producing higher quality outputs
Mm-hmm.
in these
Yeah.
students.
Yeah. I don't know. I don't know why either. I mean, one of the things that I have really been an advocate for in some of the choice programs that have passed in recent years, and I'll continue to push it. Um, for new states that are adopting new programs, and that is to always have a component where they're getting feedback from families about how the program is being administered,
Mm,
about how they're using the program, right?
hmm
I just think um, that real sort of user data is really important,
Yeah.
right? And maybe you could ask that of education service providers that are participating
hmm
as well. So don't ask the parents. Of course, parents. I want to have kind of a paramount place for parents, but also ask the education service providers, ask the schools, ask the tutors. Hey, how's this program working? What could be improved? What could allow you to do more,
hmm
right, with your time and be more effective? But really asking the end user how it's going, and asking
Yeah.
the participants, I
hmm
guess, how it's going, because then you're getting that self-reported data.
Okay. Yeah. So it's like
Um,
a different. It's a different um, access point for where you're self-reporting.
yeah, I think so. And it's just we can get lots of quantitative data from education statistics,
hmm
but there is some qualitative data that's important also.
hmm
And I think having a mixture of both of those things is pretty important.
So I was just about to ask what your take on data usage was as it pertains to how he was describing
Hmm.
their utilization of it versus what schools, um, how schools are using it.
Okay, well, I loved his example of the procedure that if I try to name it, I'll botch. But
hmm
there's a procedure that he talked about that was he called it dogma when he was a resident,
Yep.
when he was going through his medical training, and then over time they said actually it's not really benefiting anybody.
So they changed it.
Okay, so they changed it. Well, I got news for you. Come into the education sector. There are lots of things happening. There are lots of places. You and I were talking about the U.S. Department of Education. You used to work there. There are a lot of uh, offices there, a lot of personnel that you kind of go, hey, maybe this had a purpose at one point, but what's the purpose
Does it now? Yeah.
any longer? And I
hmm
think we should just be willing to ask those questions and let the data inform that. I think the
hmm
use of data in a lot of K-12 education that I've seen, it's just like somebody learned how to make a pie chart,
Yep.
but they don't know what to do with it.
And it's almost like we're numb to some of the data that's still coming out. The literacy rates, they're
Hmm.
abysmal.
Hmm.
I don't see nearly as many
Nobody's
people
rioting in the streets.
reacting,
Yeah,
yes, to that.
yeah.
I have to imagine if you had, patient, um, reaction rates that were equally as abysmal, you
If
would never
if
have
yeah, great point.
people going back to that hospital.
If
You
only
would
one
not.
out of three patients
Yeah.
left their medical, you know, their healthcare provider um, on the road to recovery, that would be a problem.
Right.
That
You
would be
would
a problem.
you would lose business, to say the
You'd lose
least.
business, you'd lose your licenses, right? The whole
Yeah.
thing. Yeah.
And it's just
Yeah.
not viewed the same way. And so the use of data to inform statistics and public opinion in healthcare is really important.
Hmm.
And it's an act of transparency, and people make decisions based off of it. But the use of data in education, like, are people not paying attention to it? I don't think so. Are they choosing to come up with reasons or almost excuses as to why the data is what it is? Well, it's a dynamic issue, and there's lots
Hmm.
of different
Hmm.
factors at play outside of schools. Or are we just not addressing it the way it needs to
Hmm.
be addressed?
No, it's a good question, and I'd love to to know when folks think about what Dr. Sand said about like appreciating that people are fallible.
Mm-hmm.
But when I heard him describe it, he sort of says, hey, people are fallible. Let's figure out a way to use that to actually improve the system.
Mm-hmm.
That's different than from saying people are fallible. So I guess this is the best we can do, right? It's a very different mindset. And so
Completely.
some of it's just a mindset shift. And I wonder what it would take to get to that in the education space.
Yeah, I'd be curious, and maybe that's a good sort of question to leave our
Mm-hmm.
listeners with. And I'd be really interested to hear how people react to that thought, how they use data themselves, and what it feels like to actually internalize the data that's being put out by both healthcare and the medical industry, and also the education world.
Yeah, well, that's a good place to leave it. So thanks again for the conversation.
Awesome. Thanks, Shaka.